The effects of blood flow restriction therapy on orthopedic injury rehabilitation and human performance. Presented by Matthew Alexander G., April 10th, 2020, for the Jacksonville State University. Introduction. Every year, thousands of Americans suffer from orthopedic injury. Physical therapists and their partners, athletic trainers and occupational therapists, and even physicians are constantly looking for tools to help patients. This includes different rehab protocols or modalities such as BFR. Blood flow restriction therapy is believed to be the next great modality in rehabilitation. Strength and conditioning coaches are also looking for the next best tool to use during training and also believe BFR could be the solution. BFR is the application of a tourniquet that is set to a specific pressure in order to occlude the venous return of blood. It is believed that BFR could produce the same or greater increases in hypertrophy and strength while using a light load compared to traditional heavy load resistance. This is very important in rehabilitation and in strength training when it may not always be the best idea to use a heavy load, such as in the middle of the season or after somebody has had a surgical procedure such as an ACL reconstruction. The purpose of this literature review is to look at the effectiveness of BFR therapy on orthopedic rehabilitation and human performance. The effectiveness of blood flow restriction versus heavy load resistance training during post-surgery rehabilitation of anterior cruciate ligament reconstruction patients. The purpose of this study was to test the differences between light load BFR and heavy load resistance training on post-operative ACL patients. The researchers recruited 28 patients, and each patient was randomly placed into either heavy load resistance training or BFR with light load resistance training. Both groups completed 8 weeks of single leg press with standard rehabilitation exercises twice a week. To measure the outcomes, researchers used isotonic strength, muscle morphology, self-reported function, and Y balance test. Outcomes. Patients from both groups increased 10 rep max. Similar increases in muscle thickness. This means that the quad girth grew for both groups. The BFR group did see a higher increase in function, Y balance, and a decrease in knee pain. This is a very important point to remember. Clinicians did conclude that BFR can improve muscle hypertrophy and strength with a greater reduction in knee pain, which is crucial for rehabilitation. Low load resistance training with blood flow restriction decreases anterior knee pain more than resistance training alone. The purpose of this study was to evaluate if the combination of BFR with low load resistance training would significantly reduce anterior knee pain when compared to low load resistance training alone. To do this, the researchers recruited 40 adult males suffering from anterior knee pain. Participants were randomly placed into a BFR or low load resistance training group. Participants completed one session that included a pre-test, intervention, and post-test. The only difference between the two groups was the use of BFR. To measure this, each participant completed a shallow single leg squat, deep single leg squat, 20 centimeter step down, and a pain scale from 0 to 10 before and after testing. Outcome. There was a significant reduction in anterior knee pain in the BFR group following the intervention when compared to the low load resistance training group. Most patients in the BFR group saw a decrease in pain for at least 45 minutes after intervention. The clinicians concluded that BFR significantly reduced pain in functional activities. They also implied that BFR could be used in order to provide a window of decreased pain to perform exercises that normally cause pain. Blood flow restriction training after knee arthroscopy. The purpose of this study was to assess the validity of using BFR and post-operative knee arthroscopy in order to improve long-term quad strength. Methods. A group of 17 volunteers were split into BFR or non-BFR groups. and underwent 12 physical therapy sessions. The same protocol was followed except for the use of 3 specific BFR exercises, including leg press, knee extension, and knee flexion. The researchers measured thigh girth, physical function, knee osteoarthritis outcome, or KOOS, and strength testing. Outcome. The BFR group increased strength by 2-fold over the non-BFR group. There were considerable increases in muscle girth, physical function, and KOOS in the BFR group when compared to the non-BFR group. Researchers did conclude that BFR is an effective intervention following knee arthroscopy. Blood flow restriction does not improve quadriceps strength after anterior cruciate ligament reconstruction. The purpose of the study was to evaluate the effects of BFR therapy in ACL reconstruction patients before and after the use of BFR. To do this, the researchers recruited 36 patients and split them into 2 groups. Patients completed bi-weekly rehabilitation for 8 weeks, with 1 group receiving BFR. The clinicians measured bilateral isometric and isokinetic quad strength before and after the intervention. The strength tests were actually performed before the patients had surgery to give it as accurate a strength test as possible. Outcome. There was not a significant difference between the BFR and non-BFR group at the conclusion. BFR did not improve isokinetic strength testing between the baseline and post-intervention, but do remember that there was a surgery in between. BFR did not improve isometric strength when compared to baseline. Clinicians did conclude that 8 weeks of BFR did not increase quad strength and may not be warranted in post-operative ACL patients. Blood flow restriction therapy preserves whole limb bone and muscle following ACL reconstruction. The purpose of this study was to determine if BFR provided any additional benefits when added to standard physical rehabilitation with regard specifically to preserving bone. To do this, 14 young adults were recruited and split into a BFR or a control group. The participants completed 12 weeks of therapy following the exact same protocol with the exception of BFR. Measures. The clinicians measured bone mineral density, bone mass, lean muscle mass, and functional assessments were measured before, during, and after the intervention. The outcome. The BFR group saw a considerable increase in muscle mass at 12 weeks post-op. They also saw an increase in bone mineral density at the 12-week mark. There were similar improvements in functional testing between the groups. This led the researchers to conclude that the addition of BFR appeared to help protect the bones involved in ACL reconstruction. Researchers could not prove that BFR greatly improved muscle strength when compared to standard rehabilitation. This study basically proves that even the use of BFR, if it does increase bone mineral density after an ACL surgery, is going to be very important because the doctors have to drill into both the tibia and the femur to perform an ACL surgery. So the bone health is going to be very important. Benefits of resistance training with blood flow restriction in knee osteoarthritis. The purpose of this study was to study the effects of low-intensity resistance training when paired with BFR patients suffering from knee osteoarthritis. Clinicians recruited 48 women suffering from knee OA and randomly placed them into one of 3 groups: BFR, low-intensity resistance training, and high-intensity resistance training. Patients completed 12 weeks of bi-weekly physical therapy, so they did follow a different protocol for this. To measure outcomes, clinicians used a 1-rep max leg press, 1-rep max knee extension, physical function test, quadriceps cross-sectional area or CSA, and self-reported quality of life. Outcomes. The high-intensity resistance training and the BFR showed significant increases in 1-rep max leg press and knee extension following intervention. There were no serious differences between the two. The high-intensity resistance and BFR also showed similar results in CSA tests. BFR did see a significant increase in self-reported quality of life following the intervention. This led researchers to conclude that BFR is similarly effective as high-intensity resistance training to increase muscle strength, CSA, and functionality, while also improving quality of life and decreasing pain. Blood flow restriction resistance exercise for older adults with knee OA. The purpose was to assess the safety of BFR training in older adults suffering from knee osteoarthritis and to compare BFR training to moderate intensity resistance training among older adults with knee OA. Moderate intensity is believed to be about 60 to 75% of heart rate max or 1 repetition max. To do this, clinicians recruited 35 participants and placed them into the BFR or MIRT group. The patients then completed 12 weeks of physical therapy with their respective groups. This was 2 different protocols. To measure outcomes, clinicians studied the unilateral knee extensor strength, walking speed, current pain level, and lower extremity function. Pain level was assessed before and after interventions. Outcomes. Both groups increased knee isokinetic torque. Both groups were able to decrease their walking speed by 3 seconds over a 400-meter walk. The efficacy analysis displayed similar results for both groups, but BFR did see a greater decrease in pain levels. Researchers concluded that BFR is not only safe, but may also be recommended for use in patients with knee OA due to significant decreases in pain levels. Quadricep strengthening with and without blood flow restriction in the treatment of patellofemoral pain. The purpose of this study was to determine if BFR is a viable method of treating patellofemoral pain by providing a method of low-load quadricep strengthening. To do this, they used 79 patients and placed these 79 patients randomly into the BFR or control groups. The intervention lasted a total of 8 weeks. Measures included pain scale, isometric knee extensor torque, and quadriceps thickness. Outcomes. The BFR group saw a 93% greater pain reduction with activities of daily life or ADLs than the control group. BFR did see a greater increase in knee extensor torque. There were no significant differences for quad thickness. There were also no differences between the 2 groups 6 months following the end of the intervention. The researchers concluded that BFR only significantly decreased pain with ADLs following the 8-week protocol, and that there were no noticeable differences between the groups, and thus BFR may not always be a viable option. Eccentric, but not concentric blood flow restriction resistance training increases muscle strength in the untrained limbs. This study was performed to examine the effects of low-load eccentric only BFR and low-load concentric only BFR on the cross-education of untrained limbs. To do this, 36 untrained women were randomly assigned to the eccentric, concentric, or control group. Participants completed training on one arm 3 times a week for 5 weeks. They focused specifically on forearm flexors, and the women in the eccentric group only did eccentric loads, and the women in the concentric group only did concentric with their BFR, and then there was a control group that did both without BFR. To measure this, the contralateral arm was tested for eccentric peak torque, concentric peak torque, maximal voluntary isometric contraction, muscle thickness, and muscle activation. So they're actually trying to see if there was a crossover symmetry or a crossover benefit to these patients. The outcome. The eccentric BFR group saw an increase in torque from 0 to 2 weeks. Neither group saw a significant change in muscle thickness. All groups saw an increase in EMG activity, and this is normal in untrained patients once they begin training. Researchers were able to conclude that 4 weeks of eccentric BFR resulted in cross-education of the forearm flexors in the untrained arm. Now, the important point was noted that the increases in strength are likely from the modality of training, meaning the eccentric training, and not the use of BFR. It is well known in strength conditioning that eccentric training produces some of the best benefits for strength. Effects of blood flow restriction training with protein supplementation on muscle mass and strength in older men. The purpose of this study was to examine the influence of BFR training with a collagen hydrolysate supplementation on muscle mass and function in older men at risk of sarcopenia. To do this, researchers took 37 healthy men who were at least 50 years old and placed them into a BFR with supplementation group, a BFR with a placebo, or a no training plus supplementation. Participants took the supplement daily and completed training sessions 3 times a week for 8 weeks. To measure this, they used an isometric leg strength, metabolic parameters, and an MRI for cross-sectional area. Outcome. The BFR group did see a significant increase in muscle CSA. The BFR and supplementation group saw an increase in muscular strength when compared, and there were similar results for the metabolic parameters. Clinicians did conclude that low-load BFR was a viable option for facilitating muscle hypertrophy in older men was a viable option. While the addition of collagen hydrolysate was insignificant. This means that the researchers basically say that the supplement that the men were taking didn't really do anything for them. Proximal, distal, and contralateral effects of blood flow restriction training on the lower extremities. The purpose of this study was to determine the efficacy of BFR training on muscle groups both proximal and distal to tourniquet placement, as well as the contralateral non-BFR extremity. To do this, they took 26 participants and randomly placed them into a low-load training protocol or a low-load plus BFR training protocol. Participants only trained one leg twice a week for 6 weeks, and the cuff was placed as proximal to the body as possible on the leg. To measure the outcomes, knee and hip strength were tested. Plantar flexion strength was also tested since that would be distal to the cuff, and leg circumference was measured right underneath the gluteal fold. The outcomes. The BFR group saw a greater increase in leg girth and all strength metrics than either of the other two groups. The BFR limb saw greater increases than the non-BFR limb in the same individual, meaning that if the cuff was placed on the right leg saw greater increases than the left leg. The non-BFR limb did see greater increases than the control group's contralateral leg, meaning that if I was placed into the BFR group and I had the BFR cuff on my right leg, my left leg was stronger than somebody who did not use BFR at all compared to their left or their untrained leg. Clinicians concluded that BFR training does produce substantial increases in strength and girth, and the contralateral limb may benefit from a crossover effect. Efficacy of blood flow restricted low load resistance training in women with risk factors for symptomatic knee OA. The purpose of this study was to assess the efficacy and toleration of BFR during low load resistance training to improve quad strength and volume in women with knee OA factors. 40 women were randomly split between the BFR and control groups. Participants met for physical therapy 3 times a week for 4 weeks, and all participants followed the same protocol with the exception of BFR. Measures include 1 rep max leg press, isokinetic quad strength, time to climb 8 stairs, muscle CSA, and the Coos score. The outcome. The BFR group saw a significant increase in 1 rep max leg press. Both groups saw positive results in stair climb speed. Neither group suffered a worsening of pain, which is an important factor. Researchers concluded that an average load of 30% of 1 rep max combined with BFR appears to be sufficient to increase knee extensor and leg press strength. This is important for patients who, once again, may not be able to use high intensity resistance. Blood flow restriction resistance exercise promotes lower pain and ratings of perceived exertion compared with either high or low intensity resistance exercise performed in muscular failure. This study was done to compare ratings of perceived exertion and pain perception between conventional resistance protocols and a BFR protocol. To do this, 12 men who had not strength trained in 6 months were placed into a BFR high intensity or low intensity resistance groups. And they weren't actually placed into those groups. They each did 3 separate sessions consisting of BFR, high intensity, and low intensity resistance. Measures include 1 rep leg press, 1 rep max leg press, pain from 0 to 10, and rate of perceived exertion. Outcome. The high intensity resistance and low intensity resistance had similar rate of perceived exertion responses and were higher than BFR. BFR had the lowest pain perception. Authors concluded that BFR did not promote lower levels of pain and RPE. Low intensity rowing with blood flow restriction over 5 weeks increases VO2 max in elite rowers. This study was done to study the effects of BFR on maximal oxygen uptake, or VO2, during low intensity rowing. They used 31 elite rowers and assigned them to either a BFR or control group. Participants completed training 3 times a week for 5 weeks, consisting of rowing strength and cross training, and were told to continue their normal training sessions. The clinicians studied endurance, VO2 max, and 1 rep max squat max. The squat 1 rep max was not affected by BFR. There was a significant VO2 max difference between the 2 groups, with the BFR group seeing the largest increase. Researchers concluded that BFR did increase VO2 max. Blood flow restriction therapy versus standard care for reducing quadriceps atrophy after anterior cruciate ligament reconstruction. The purpose of this clinical review was to determine if BFR was more effective than standard care for reducing quad atrophy following ACL reconstruction. Researchers reviewed 3 clinical trials that directly compared BFR to standard care. Outcome. Researchers concluded that further research was needed. Future research should evaluate the effects of BFR not only on quad atrophy but strength. Researchers also questioned the safety of BFR, stating that there are multiple side effects. Eccentric and concentric blood flow restriction resistance training on indices of delayed onset muscle soreness in untrained women. The purpose of the study was to determine the effects of low-load eccentric BFR and concentric BFR resistance training on the indices of delayed onset muscle soreness of DOMS. 25 women were recruited and placed into eccentric BFR or concentric BFR. Participants completed 7 days training the forearm flexors. The measures were self-reported muscle soreness from previous training. The outcome, there were no significant differences between the 2 groups, and researchers concluded that neither low-load eccentric or concentric training resulted in DOMS when paired with muscle soreness. Effects of blood flow restriction without additional exercise on strength reductions and muscular atrophy following immobilization. The purpose of this was to investigate whether BFR without concomitant exercise mitigated strength reduction and atrophy of thigh muscles in subjects under immobilization of lower limbs. Methods. Researchers searched multiple databases using the terms BFR, vascular occlusion, KOTSU, immobilization, atrophy in clinical trials. This only resulted in 3 articles to review. The outcome, 2 studies reported that BFR did help reduce loss of strength. All 3 studies reported that BFR could help to reduce atrophy. The authors did report that there was a large potential of bias in the articles. Authors also concluded that the use of BFR could help to reduce atrophy and loss of strength for patients in immobilizers. Neuromuscular effects of dorsiflexion training with and without BFR. The purpose of this was to study the neuromuscular activity during low-load dorsiflexion training of the tibialis anterior, or TA, with and without BFR. To do this, 16 subjects were split between BFR and control groups, and they completed 2 training sessions of their dominant leg. Measures included the EMG activity, self-reported measures of pain, discomfort, fatigue, and difficulty. EMG amplitude was higher in the BFR group for the last 20 repetitions during training. BFR patients also reported more fatigue after the intervention. Clinicians concluded that BFR might allow subjects to train at a higher intensity without altering the neuromuscular system. Intermittent BFR does not reduce atrophy following anterior ligament reconstruction. The purpose was to evaluate the effects of BFR on reducing quad atrophy in athletes following ACL reconstruction. To do this, 24 participants were recruited and placed in the inclusion group or control group and taught the at-home protocol. The intervention began 2 days after surgery and would end 16 days after surgery, and the only measure was an MRI for CSA. Both groups saw a significant reduction in quad atrophy after the intervention. Researchers concluded that intermittent BFR did not reduce quad atrophy in athletes during the first 16 days following ACLR. The effects of body weight-based exercise with blood flow restriction on isokinetic knee muscular function and thigh circumference in college students. Purpose: to investigate the effects of body weight-based exercise with BFR on muscular function and thigh circumference. To do this, 17 college students were split between BFR and control groups, and the study lasted 3 days a week for 6 weeks. The measure was isokinetic knee extension and flexion test along with thigh circumference. Both groups increased knee flexion strength. BFR did see a significant increase in thigh girth following intervention. Researchers concluded that BFR was a viable option to increase knee function and thigh girth. Low load resistance training with blood flow restriction improves clinical outcomes in musculoskeletal rehabilitation. Purpose was to evaluate the efficacy and feasibility of low load BFR when compared to conventional high load resistance training on patients undergoing lower limb rehab. 28 men undergoing lower limb rehab were randomly placed into the BFR or resistance training groups. Outcome measures include CSA, 5-rep max leg press, multi-stage locomotion test, Y balance, and visual analog scale for pain. Neither group reported changes in outcome measures. BFR saw a greater increase in quad volume. Resistance training saw a greater increase in 5-rep max leg press. BFR saw a greater increase in MSLT and Y balance. Research concluded that BFR was safe and feasible. In conclusion, BFR needs to be further researched. Several articles claimed BFR was effective, while others claimed it was ineffective. The majority of the research also has a high potential for bias. If you really look at how these studies were performed, along with who did them, there is a very high potential for bias. BFR could be very dangerous with issues such as venous thrombosis, cardiac complications. You have to be very careful with BFR and very careful with your patients and really understand who they are, what they're going through, if they have high blood pressure, stuff like that, to make sure that BFR is a safe use for them. Ultimately, this literature review does show that there can be positive outcomes for the implementation of BFR into rehabilitation and strength protocols. The main benefits are increases in girth, which is a decrease in atrophy, which is very important following any sort of surgical intervention. We want to get muscle size back as quickly as we can because muscle size is correlated with muscle strength, and a decrease in pain. This alone is a reason to use BFR. If we can decrease pain, which is one of our main goals following surgery, we should. Recommendations. Further studies should use a longer timeline, meaning greater than 8 or 12 weeks. I would like to see a 6-month timeline. Future studies should compare traditional protocol with BFR protocol for the entirety of your rehabilitation, meaning the entire length of an ACL rehabilitation, which is about 6 months. Future strength protocol should also compare a BFR strength protocol with a traditional strength protocol over several months, not 2 to 3 weeks, meaning the full phase, the microcycle, the macrocycle, whichever you want to do, because there is periodization built into strength protocols, and a short time frame does not allow that to be seen. Future studies should refine what percentage of limb occlusion pressure and what percentage of 1-rep max should be used in order to get the best results. Currently, we are using 50% for upper limb and 80% for lower limb of occlusion pressure. Is this safe? Is this the best percent? We don't really know. And what percent of 1-rep max should be used to get the best results? Most studies are using 30%. Can we use more? Should we be using less? Once again, we don't really know. Thank you for watching my video, and I look forward to hearing back from you.